Welcome everyone to the Cervos Medical Masterclass. My name is Dave Briggs and I'll be your commentator. We have a truly exceptional faculty to present the clinical research behind promising minimally invasive alternatives to traditionally open orthopedic procedures. Before we begin, one reminder, be sure to make frequent use of the Q&A button at the bottom of your screen. Thank you for joining us today, and it is now my pleasure to introduce our moderator, Robin Young, publisher and editor of Orthopedics This Week. Robin, the program is yours.
Thank you, David, and thank you to all of our attendees today. Autograft is the gold standard for bone repair. Simply put, cells repair bone. By focusing on the recent insights regarding the biology of marrow and healing, we can improve on this gold standard by changing the way we source autologous bone and aspirate. Changing the fluid dynamics of marrow aspirate and capturing intact living dowels improves the flexibility of the biologic harvested, which also affords new and less invasive, even novel surgical techniques without sacrificing the cellularity of the biologic. Not every patient with severe osteoarthritis of the knee is an ideal candidate for total knee arthroplasty, and the cost and morbidity of open, non-union, or other bone grafting procedures is problematic in today's healthcare environment. Today's faculty will discuss clinical studies, including one with 15-year follow-up. They'll also review optimal patient profiles for these approaches, and there's even a cadaver lab today demonstrating techniques and looking over some other practical considerations. I think we have a really outstanding faculty today. Dr. Jeff Chabot, who is the co-founder and director of Endo Solutions and co-inventor on core technologies, is giving a very interesting talk. Dr. Anil Ranawat, who's chief of the hip and knee division of sports medicine at HSS, and Dr. Taylor Reif, who's the assistant attending orthopedic surgeon also at HSS, will also be giving presentations. Now we begin with our first speaker, Dr. Jeff Chabot.
Hello, and thank you for that introduction. Am I being heard? I hope so. Okay. Today, as we said, we're going to hear, the presentation is going to come in three parts. First, I'll begin by discussing a bit the scientific vision that we have at Cervos for the tools that we want to be able to place into your hands. Then we'll hear Dr. Ranawat will give us a presentation on repairing subchondral bone for joint preservation. And Dr. Reif will tell us about clinical opportunity to improve bone grafting. Then we'll hit the cadaver lab and close with some Q&A. So please do submit questions through the online Q&A feature. So at Cervos, the scientific vision that we try to incorporate into all of our products really fits together as sort of four pieces. One, and primarily, is that we're trying to leverage the science of natural healing. We're trying to see how does the body normally repair injury, and how can we enhance its ability to do so for those cases where the natural healing just isn't enough. We try to develop tools to enable a percutaneous approach with less trauma, basically. So as the body can put its energy towards repairing the injury, not repairing the comorbidities that are introduced by a non-percutaneous approach. We want tools that are simple to use, but that deliver consistent quality results. When you use our devices, you know that what you're going to get from them. And finally, when we think about our products as a suite of products, we want to make sure that they have synergistic uses. So for example, that properties like the length and the gauge of needles enables one needle that you might be using for one procedure to serve as an introducer for another needle to, say, for example, deliver a bone dowel in the subchondral space. A lot of our scientific vision and the tools that we have are built around the biology of bone formation and how does bone marrow help to repair injuries in general. And what is well known is that mobilized cells from the bone marrow are absolutely critical to the body's ability to self-repair injury or trauma, which in 99% of cases is sufficient. So at the site of injury, growth factors and other signaling molecules will be released that recruits these cells to move from the marrow to that space and really guide the repair there. But we know that for some patients, the natural ability of the body to heal is just not quite up to the task. And this can happen because of advanced age, because the trauma is just too extensive to be repaired naturally, perhaps because there's another disease that's at play, or sometimes there's an injury to poorly vascularized tissue, and so these cells just have a hard time getting to where they need to be to affect the repair. And what we're really hoping to demonstrate through, for example, tonight's program, is that a minimally invasive surgical approach can work in large defects. And that's really going to help avoid that donor site morbidity, where you're basically giving the patient two injuries they need to heal, the one that we're trying to fix, and then the one from where the bone was harvested. So in this case here, you can see a jaw repair that was needed because of a case of cancer where the jaw had to be irradiated and cut away. And so normally, historically, we might think, okay, we'll do autografts. We'll take a large chunk of the patient's hip, grind it up, and use that to sort of rebuild the jaw and have bone grow in there. But in this case, this was done through entirely percutaneous bone graft. You can see the components over on the right. So we have bone marrow, we have a graft extender, and we have these bone dowels harvested, again, percutaneously from the donor tissue, all put together to enable this person to really have their jaw rebuilt. And that meant that their body could focus on healing their jaw, not on having to also heal their hip. There are, a number of cases that are prime candidates for this percutaneous bone grafting approach. One is repair of subchondral bone. When we think about joint preservation, we don't only want to treat the part of the joint that's outside the bone. We want to also treat the part that's inside the bone. And if we can do that, again, percutaneously, that's so much the better for the patients. Also, the repair of weakened bone in cases of non-union, bone loss, fracture gaps. Other cases where we might need to fuse bone, spinal fusion, for example. And one thing to note, as we hear about the use of the percutaneous delivery of bone dowels for subchondral lesions, is that when you have weakened bone in a non-union, it's histologically very similar to those lesions. And so when we see this process, procedures that seem to work very well in subchondral lesions, we have great hope and confidence in success for fixing non-unions as well. So with that introduction, I'd like to introduce our next speaker, Dr. Anil Ranawat, who's as was mentioned, the chief of the Hip and Knee Division of the Sports Medicine Institute at the Hospital for Special Surgery. And you can see he has many other credentials, but I won't belabor the point. And Dr. Ranawat, the floor is yours.
So thank you, Jeff, and thank you, Cervos. This is a great group, and thank you, Taylor, Dr. Reif, for joining us, and Robin for a great introduction. So I'm going to be talking about really my experience with subchondral bone and how I really think of it as joint preservation. Whenever you give a talk, you have to give a disclosure. My disclosure is I am a Ranawat, which means all Ranawats do knee and hip replacements, except for me. My disclosure is that I'm a joint saver, not a joint replacer. And that's my biggest disclosure. So I've been treating subchondral bone for maybe 10, 15 years now, because I realized that cartilage is aneural and avascular. Because if cartilage was painful or vascular, then it would heal itself, and it doesn't. We attempted 15, 20 years ago, maybe 25 years ago, actually, to do microfracture to try to stimulate cartilage to regrow. But again, we were just stimulating the subchondral bone. And that's made me think that bone marrow edema is really the key to understanding pain. And it's really the key to understanding the arthritic progression to knee replacement. And understanding that the entire organ of the joint, from the trabecular bone, subchondral bone, the calcified layer, to cartilage and the synovium, is really the key to how it works. I always told patients there's an itis of arthritis. A cortisone injection works when you have early arthritis because your inflammatory milieu is very active. I always call grandma's arthritis does not work for a cortisone injection because the inflammatory milieu is gone. So understanding the interaction of all these 4 or 5 parts of the organ of the knee joint, but of any joint, is really critical. But to me, bone marrow edema is what causes pain, and what causes pain is what drives people to total knee replacement. If you look at the epidemiology literature, the drivers of knee replacement are bone marrow edema, malalignment, body weight, not degree of arthritis on an x-ray, which is a fascinating understanding, and really have to understand that the joint is an organ, and how we can manipulate that organ is really the point of my lecture and the point of my understanding of the last 15 years to go after bone marrow edema. So as I just talked about, bone marrow lesions are highly correlated with total knee. We all know that, my father always told me scoping arthritis does not work. There's been multiple papers to show that. We've also shown that, there are other substitutes, there are other people that have been going after this for many years, because bone marrow edema is actually a fascinating topic, but it's not just about decompressing it. It's also about what we're injecting into it. And I'm going to say this, is that over the last 20 years in orthopedics for me, we've been talking about fake bone for 30 years, but in my 20 years, no fake bone has ever worked. And calcium phosphates, TCPs, every biodurable construct has not worked. And really the point of this lecture is to first validate that bone marrow edema is the driver of knee replacement. Second is that autograft is always superior to fake bone. And that's what we call biological therapy. So let's look at the literature. Let's look at the father of bone marrow edema. Let's look at the father of bone marrow aspirate. It's Hernigou. So in France, Dr. Hernigou was looked at as who was the first person to look at non-unions, delayed unions, and I don't want to steal Dr. Reef's thunder, but how he attacked that and how really found the power of CFUs of bone marrow aspirate. He then was saying, okay, let's look at this aspirate and let's look at another subject matter, not just non-unions, CFUs, but can these CFUs call that bone marrow edema from overload? Can it heal it? So this is a randomized prospective trial, 15 years of data, 140 patients in each arm, total knee and BMAC. And basically the BMAC was almost as effective than total knee in terms of pain control to postpone total knee. So people with advanced arthritis in both knees, the BMAC control arm prevented knee replacement for 5, 10, 15 years. Very impressive data. But let me tell you this, it was a very laborious BMAC concentrate. It was over 500 cc's of blood draw, really almost 1/10 of your blood volume. Similar protocol, similar study, but this time 30 knees, stage 4 AVN, again, a total knee group and a BMAC group. And again, what they're showing here is that, total knees are not benign. They have a higher complication rate. They have a longer recovery. BMAC is benign in terms of injecting BMAC into bone marrow edema, very low complication rate, very quick recovery. It's you get up and go. A knee replacement, there is a thing called the forgotten joint index. A total hip and a partial knee are high in the forgotten joint index. A total knee is not. And 1/3 of all total knees still have continued pain. And we'll hear about that later in our patient testimonial. Lastly, we want to look at another study of 60 patients, randomized, prospective, bilateral, stage controlled, really, really good study, again, from Dr. Hernigou, where he was now looking at, okay, so BMAC works, but where do I put it? Do I put it in the subchondral bone or do I put it in the joint? Again, 15 years of follow-up, and he showed that both had benefit, but clearly putting the BMAC in the subchondral bone was superior. You're really bone grafting effectively with CFUs, the area of bone that's overloaded, right? If you think of the Leaning Tower of Pisa that's falling, the flying buttresses that are created to restore it from falling more or the churches of Europe, those flying buttresses, is the BMAC. It is the bone grafting. And that's literally what we're doing. We're creating flying buttresses. So then we want to talk about, well, what's better? Is it, if BMAC is so great, is it better in the joint or in the bone? Well, clearly it helps in the joint as well. I've been using BMAC for every knee scope for the last now 5 years. It reduces joint inflammation. It helps cartilage metabolism. It increases synovial macrophage counts. It just improves the joint homeostasis. The patients have less pain and recover quicker. So clearly the interarticular version of BMAC, which to me, if you talk about PRP, PRP has biological activity, but BMAC is 10 times the biological activity of PRP. But then we want to think about, again, let's compare BMAC to interarticular to bone. And basically, although they both help, it also supports that bone is a little bit better, but still just in the joint works well enough using WOMAC scores on interarticular versions of BMAC. So if you want to summate the entire clinical work we have on looking at BMAC for early or advanced arthritis, I mean, this is as a substitute or as a delayer to total knee replacement, really going after the big dog in the house, is that sometimes adding biological, I call it buttresses, to the medial compartment can delay total knee for upwards 5, 10, 15 years. If you focus on the subchondral delivery, that maximizes the buttress, but there's still benefits to intra-articular. So ideally, the plan should involve both sides of the joint. That's really how I see it. If you have overload, that's how you can kind of retrain the knee joint from a hot knee, a lot of synovitis, a lot of bone marrow edema, to more of a dry knee where no bone marrow edema, less synovitis. But the one thing we've learned from this kind of concept is that the Hernigou system, although impressive, his data, is not really practical. It's huge blood draws, 300 to 500 milliliters, multiple puncture holes of the iliac cracks. It's taken outside the body and manipulated, which is illegal in the US. And there's about 4 to 5 hours of process times. It's very labor intensive, just not a North American argument. But this is a North American argument. Just using good concentrated BMAC on an overload knee compartment, which you see on the left, when you see it, again, most likely from a root tear, early arthritis, injected with BMAC, and you see resolution of bone marrow edema. This is why I always told, questioned my father that my father never had a knee replacement because he had symmetric alignment and had low body weight. He never overloaded his compartment. But if someone did have varus malalignment and a root tear, had bone marrow edema, and they were young enough and fit enough, then this could be a substitute to traditional knee replacement. So on that note, I want to hand it off to our next speaker, Dr. Taylor Reef, who's a partner of mine at a hospital for special surgery. He's an assistant attending. He's a member of the limb lengthening service and complex reconstruction service. I'm a sports medicine doctor. I'm a joint saver. He's coming at this subject from a totally different perspective, more on the trauma, limb lengthening, bone reconstructive side, which shows you the versatility of BMAC. He's an Anakin Fellow, and he comes from us from Loyola University Medical Center. We did his residency, but he also did his fellowship at HSS. So Taylor, please take it away.
All right, thank you so much. Thanks for having me tonight. Here we go. So yeah, I treat non-unions as part of what I do in terms of complex reconstruction here at a hospital for special surgery. So, non-unions come in a variety of, bones. And, of course, when I'm treating them, I'm looking at the bigger picture, and I want to both know what happens to the mechanical stability of the fracture. And that's probably one reason why it didn't heal. But I'm also thinking about what happened to the biology of, that fracture, and why didn't it go on to healing? Did it not have enough cells? Was there a lack of matrix? Was there a lack of vascularity? But a lot of these factors that I'm looking at, I'm thinking, well, if I'm going to replace all those things, I need to replace that with the right bone graft. And our own bone is always going to be better. Autologous bone graft is going to be the best bone graft because it's going to both contain cells, it's going to contain scaffold, and I think a lot of us forget that when we take bone graft from the iliac crest, we're getting a lot of these osteoinductive factors from within those cells. So, we don't necessarily need to run to a product or, go to these recombinant BMPs that are, very super physiologic in how much BMP they have. And a lot of that is probably just being wasted when we probably just need the right amount that's coming from, our own cells. So if we look at our red marrow and how that changes with age, it happens in a predictable pattern in humans, and you start to lose it distally first, but the pelvis maintains that reserve of red marrow for much longer into our lives. So if we're going to go to a source that's going to have the best bone marrow for us to go get those cells, to get those scaffolds, and to get those osteoinductive agents, I'm going to go to the bone marrow in the pelvis. And the iliac crest is, pretty readily available, and it's, I can, put a needle right there and be on the iliac crest. So, those cells are attainable pretty easily if I need some bone graft. And so we talked about the Hernigou kind of BMAC technique, and he also published this to compare those results that Dr. Ranawat looked at. He also looked at those in non-unions, 60 tibial non-unions that were treated with an X-fix, a very simple X-fix, as well as a BMAC, and a pretty standard population of tibial non-unions that you would expect: some tobacco smokers, some people with diabetes or steroid use, a lot of open fractures. And what he found was that most of these were treated successfully just by improving the stability and injecting BMAC. And he even went further and showed that, the ones that had over 1,500 of the colony-forming units, showing that, there was enough mesenchymal stem cells there, those were able to go on and heal their fracture, showing how powerful the cells are on healing that bone. But one thing that, we've talked about multiple times is that, it's a big procedure, and some of that success comes, from the amount of blood and bone marrow that he was able to get by taking 300 cc's of aspirate, going to both sides of the crest, 4 hours of processing time. So I think, that's not really realistic in my practice to do that. So there needs to be a more practical way to get that. And so there are traditional methods that we've, of course, done for years now, one of which is to go with an open approach to get iliac crest. And, you can use gouges or an acetabular reamer and things, but these create an incision. They're painful. You'd rather not have to add this whole another surgical step if you don't have to. And, the traditional bone marrow aspirate that a lot of people are going to be familiar with, you end up just drawing up a lot of peripheral blood. And then you have to concentrate that with some sort of centrifuge, and that's going to break down some of those cells, and you may not get exactly what you want in terms of your bone marrow. So neither of these are perfect. So we really need tools that get us the graft we want without a lot of futzing, that we can do quickly, that we can do at the start of the case, so that we can move on to start correcting the non-union, for instance, that we're really there for. So I think dowels are a great solution because you kind of get everything you want in your bone graft. And this can be collected percutaneously. You get your scaffold in the trabecular bone. This is going to be loaded with the cells that you want, with those red marrow cells. They're going to have the mesenchymal stem cells that you need, and the CD34 cells are going to have the osteoinductive BMPs, PDGFs, and everything is part of them as well. So, and then the aspirate, the way you get around aspirating all that peripheral blood is that these canals that you create when you go into the iliac crest fill with blood, of course. And if you're just going from the end of the needle, you're going to be sucking up all that blood. And what you really need is to get to new sites of bone marrow each time you're aspirating those cells. So, as you go up, that you're feeding this in from the side of the needle and getting better bone graft while still minimizing morbidity. So what's a practical solution to this? unlike the one we talked about with Hernigo, is, in a couple minutes, you can take needles, you can go into the iliac crest, and then you can get mesenchymal stem cells of the same count as those concentrated varieties without, the huge aspirates and the long time courses. And it's still minimally invasive. It's percutaneous. This is something done, just through the needle poke. And then if you need more than 5 cc's, for instance, you take another 2 minutes or maybe go to the other crest, or maybe go to another puncture site. But either way, these are going to be kind of minimally invasive procedures that are easy to heal. And we've kind of talked about the not practicality of the other way of going about this. So, these are all the things you can do with these minimal incision techniques. You can take a bone core from the iliac crest, you can aspirate the marrow. And then, as we'll look at in the cadaver lab, you can also remove tissue from a defect. And then you can deliver an aspirate or deliver one of those bone dowels into that space using, again, just small incisions. So, we talked about osteoarthritis, we talked about non-unions, or, a failed arthrodesis, would be another common indication for this. But I think osteonecrosis would be another, area that a lot of orthopedic surgeons see, that if we can deliver, biology to that area, then you're gonna see healing of those lesions. And this has also been evaluated more and more in rotator cuff repairs. You're looking at another area where on MRI, we see that there's bone marrow edema, we see that the bone is weakened and soft. What if we attack that area with these bone marrow aspirates? So just to kind of recap what we've been talking about, we want practical solutions to restore the biology. The axial skeleton maintains the red marrow throughout life. The progenitor cells normally, when they heal, are traveling from those red marrow to the sites of injury, but are often insufficient. So why don't we as surgeons then transplant those cells directly from where we know they are to where we want them? And, this is, like, as I talked about, this is kind of just supplementing all parts of the biologic process. So thank you very much for your time.
So before we start the next second half of the program, we're now going to get into first a patient testimonial. It's a subchondroplasty patient that had this technique, and then we're going to get into the cadaver lab approach. So why don't we open up the volume? This is an example of the picture, as I said to you, where there's clearly medial compartment overload, a root tear, and resolution of that 6 months later in the patient. So let's take it away.
Can you tell us a little bit about the clinical history of both of your knees?
In terms of the history of knee surgeries, on both knees, on my right knee, I had an ACL reconstruction about 30 years ago. And then most recently, about 4 years ago, I had a total knee replacement on my right knee. On my left knee, I've had ACL tear about 10 years ago. And there was a bucket handle tear of my meniscus. They tried to suture that, but that failed, and had a meniscotomy on that. But most recently was able to do the bone marrow procedure and have been extremely pleased with the results.
Could you tell us a little bit about how well you tolerated that procedure, and then some of the post-procedural experiences with respect to, was there a lot of pain associated with it, the recovery?
Sure. It's a very easy procedure from a patient perspective to go through, right? It's nothing like meniscus surgery or the ACL construction. So very easy. Got up off the table, off that, just walked away. In a limited period of time, a brief period of time where I had limited activity, mostly walking, but, shortly after that, added other activities in. And what I noticed really right away was I was having a lot less pain, right? So it's kind of the absence of something that you feel. And as I started adding more activity in, that was really, peculiar for me, because I was used to having to take, an Advil, Aleve, just to kind of tamp down on the pain level from that knee. And I had been told that I needed a total knee replacement on my left knee. So having had this procedure, and really noticing it probably around 3 months or so out, that I was able to do more, train more, do some weight training, and single leg exercises with it, and really, get back to some of the activities that I wanted to do and more often. That's been just a fantastic experience in terms of the results.
And it hasn't been about, what, a year and a half since you had the procedure, is that correct?
That's right.
And over that course of the year and a half, perhaps you could tell us the change in the knee, good or bad, that you experienced.
It's been all good in that knee. I wish I had done that before on my right knee before I got the total knee replacement. That's all I can say is on that. And really being able to get back to things like running, trail running, and paddle tennis and regular tennis, as well as skiing. I wasn't able to ski multiple days before. It was too painful. Now I'm skiing, 10 days in a row on a vacation. So it's really been a night and day type of change.
And finally, for patients that find themselves in your similar circumstances, would you recommend trying this procedure before going to a total knee replacement?
I highly recommend this procedure. It's so much easier to deal with than any of those other things. And again, the results have been spectacular.
Thank you, Mark. Thank you for your time today.
So, Dr. Reef, why don't you walk us through the procedural concepts of Cervos?
Yeah, absolutely. So I had the opportunity to use these products in a cadaver lab, and I'll kind of walk through using them and kind of some of the things that I saw. But so you have a sharp tip on most of them that you're going to be able to get through the iliac crest. And you can either get it through the cortex using power or a mallet, kind of whichever technique you're familiar with. I usually use a mallet, but I could see myself using power if I needed to. So you're going to remove the sharp, and then you're going to put in the blunt cannula. And so that when you advance the cannula down into the crest, you're really not able to go through the cortex. You're going to stay within the inner and outer table, which is where you want to be to get the marrow, and so to not put yourself in any danger in the pelvis. And then when you're going to take that out, and then you're going to put in the aspiration cannula that's going to do the workload to get your bone marrow, and you just need to make sure it's oriented correctly so that your needle, the holes in that needle that I showed earlier, are able to aspirate. And then this is a handle that you can attach so that you can twist the cannula back into new areas in the pelvis. So then you're going to twist that jacket down just so it locks you against the pelvis to provide a nice stable handle. And then each time you aspirate, you're going to rotate, which is going to raise the needle up into the pelvis a little bit more, and then you're going to be able to get new areas of bone marrow that you're able to aspirate. It's easy to turn, easy to use, and as you can see, each time I turn that, you're getting that cannula is coming up into the pelvis, and you're going to aspirate from a new area. And so we'll move on to, getting a bone dowel. This would be a common place you're able to get a bone dowel. Let's say if I'm going to a non-union, I'm going to see, maybe I want 3 or 4 bone dowels, depending on how much bone graft. So same thing, drill or mallet. And then I'm going to put this in a little bit further to make sure that cannula then goes into a place where it's going to go through an area of bone. So this is kind of where the bone is entering into that cannula. And then to make sure that I drilled it far enough, you can use this measuring guide, which has lines on it to make sure that, there is bone. And as you can see, they're at about 3 centimeters of bone. Again, attaching the handle. And then the spoon is what cuts the bone away from the pelvis. And then by twisting it, both directions, you're able to break off that dowel in the pelvis. And as you can see there, a nice piece of bone. And that you can see how long that takes. You could do that a couple times if you needed more bone. So now we're kind of going to show if you want to remove bone. Let's say you've got a large subchondral lesion. You want to take some of that away. You're going to advance this. The cannula goes in the same way, and then you're going to advance this piece through that necrotic area. And that you would probably want to do on power because you're going to be localized. Then you're going to make sure you went in. Same thing with this stylet. Make sure that you actually drilled in through that necrotic area. And then again, you're breaking off that area that you want to take out. And you can kind of twist these to take out the section that you want. And then here we have that, this is another dowel that I got from elsewhere. And then you're gonna, you can start with your aspirate because now you have that nice channel that's been opened by removing the necrotic lesion or the bone marrow lesion or whatever it is. And then you insert the bone graft. And then you kind of basically use this as a pusher and push that bone graft into the hole that you just created. So now you've taken out the segment you want. You've now put in the dowel that you got from the iliac crest, delivering some marrow to the section you want. And then this is another 15 gauge. It's a smaller needle that comes with it. And so this is, let's say you want to just kind of increase the the area that the aspirate goes into. You want to create more than just one channel in the bone. That smaller needle is a good way to do that. And this is just showing kind of the same process, but in, let's say I had a non-union in the distal tibia, pretty similar process. Sharp part gets drilled in or malleted in. Again, if you know where you're at, I think it's safe to mallet. And then you're going to decompress the non-union. Basically, just want to create some room in the area. So I'm just going to use, a drill in this case to open up a path. That might be fibrotic tissue. I'm going to usually localize that on fluoroscopy to make sure I'm in the non-union area. And then they actually have this little curette that you can put in that basically wiggles around and increases the area that you debride, creates a slightly larger path than the reamer was able to. And then, so again, now you have an open area that you can aspirate, or you can place your aspirate into. And then again, same thing, you've created a nice hole that you're going to transport your healthy bone dowel into. I'll use the pusher again to really deliver it in there. And how much of this you do on fluoro would be up to you. And then same thing, if I want to increase the amount of debridement that I get in the non-union area, I can use the smaller needle and then do my bone marrow injection.
That's great, Taylor. It shows you a lot of versatility to the product line.
Yeah, and it's all easy to use, things that you're going to be familiar with in the OR, drills and, sharps and cannulas and blunts. So easy to pick up.
Well, thank you, Dr. Ranawat, Dr. Reif. Those were excellent sessions. And I have to say, this is the first time we've broadcast a cadaver lab, I'll say this, it's the best we've ever done. But that was really wonderful. Hopefully, to our audience, you've been using the Q&A button. I'm looking here, I see we have a number of questions. Jeff Chavit, have you retrieved a couple? And what is our first question?
Okay, yes, we have Okay, am I on? Yes, great. Okay, we have a submitted question, which I will field, which is, with the solution aspirating needle, is there data that reflects the cell counts that were found in Dr. Hernigou's work? So Dr. Hernigout published a couple analyses looking at the difference between what ultimately led to success versus failure. In non-union, looking at CFUFs per milliliter, he found 600 was associated with failure, and 1,500 or more was associated with success. In osteonecrosis, the numbers were lower, actually, 143 for failure, 562 for success. There was a paper published by Dr. Michael Scarpone et al. In the Journal of Translational Medicine in 2019, where they determined that in the vast majority of cases, the Marrow Solutions needle was delivering 2,000 to 4,000 CFUFs per milliliter, again, without the need for centrifuge processing. So compare that with either 562 or 1,500 that was associated with success from Dr. Hernigout. So thank you for that question. We have another question, and perhaps Dr. Renowat, this would be a good question for you. If a patient received a benefit over 5 years, is this a procedure that you would consider repeating?
That's a very good question. It's based off a lot of my four factors, which is for, let's say, medial compartment arthritis. It would be based off their alignment. Did their alignment change in those 5 years? It's based off their bone marrow edema pattern on an MR imaging, and it's based on their body weight. So if all of those things did not progress dramatically, which means their body weight didn't get much worse, their bone marrow edema returned, and they had not significant change in their malalignment, then yes, of course, I would retry the procedure. But you know, the main goal for this procedure is to prevent the early knee replacement. The early knee replacement is a major problem in North America. And Dr. Reif, who does a lot of osteotomies, I do myself, you know, it's an alternative to that early knee replacement. That's a big operation. This is trying to get the 45 to 60-year-old who can't really move on, but not ready for a knee, but maybe not ready for a high tibial or distal femoral osteotomy either. And it's a bridging procedure, is the way I see it. Taylor, what do you think?
Okay.
Yeah, I totally agree with that. I mean, I think correcting alignment is great for younger people, but you know, if you can kind of sense who some of these people are when, you know, their arthritis is not so bad, and you know, we don't get MRIs on a lot of those people because, you know, we've been told that, you know, that's just going to show, you know, it's not going to give you any more valuable information. But I think this is kind of telling us that there is valuable information, and if there are bone marrow lesions that we can target, then we can, you know, change the course and, you know, prevent knee replacements from occurring in these, you know, younger populations that no one really wants to put a knee in.
Okay, thank you. Dr. Reif, the next question might be directed to you. How important do you think it is for doing the different passes with the 15-gauge needle in order to improve coverage?
Yeah, I think it depends on the size of the lesion, you know, and it depends on how many dowels I would want to put in. You know, if I'm putting in 3 dowels, you know, I'm going to have pretty good coverage. But if I'm only going to put in 1, for instance, I may want to increase the number of passes I get. And I just want to make sure if you're going to take that red marrow out of the pelvis, I want to make sure to deliver it to the area that I want. So I think making multiple passes with that 15-gauge needle, to me, kind of opens up more channels that is going to deliver that to the bone I'm interested in.
Yeah. A question, is there a correlation between age, certain diseases or medications, and the cellularity of the axial skeleton? So I'll field that one. And the answer is that there is a correlation, but across a very wide range of potential patients, you can get very high quality usable marrow out of them. Basically, if they wouldn't have enough cells in their marrow to be able to deal with the trauma associated with the surgery, you wouldn't consider them as a candidate for surgery to begin with. So, and even after age 60, age 70, you can still get high cellularity marrow out of, especially the hips. In case of some diseases, we know that in the case of, say, sickle cell disease, that can be associated with osteonecrosis of the femoral head. And patients who have sickle cell disease have fantastic cellularity of their marrow. It's basically trying to continuously replace the cells that are damaged. On the other hand, if you take a patient who's had a lot of exposure with corticosteroids, that can also lead to osteonecrosis, and it's going to cause the cellularity of the marrow to be poor. So if somebody had pursued a heavy course of corticosteroids, they might not be the ideal candidate for a marrow-based treatment.
Jeff, can I ask you a question?
Yep, please go ahead.
Yeah. So, what I love about this new product line of getting bone graft is that I could stay at the level of the knee to do a knee procedure. I can, core out it, either from the tibia or the femur, and get a nice bone dowel, 1 or 2, easily. I was always a little bit more conservative to get my BMAC from around the knee. What is your gestalt of CFU units from the crest versus just an aspirate from around distal femur proximal tibia?
I can't say that we've done a lot of counts on marrow collected from places outside the hip, frankly. We know that those are some of the first places where it really is as you age that the high quality marrow really retreats to this sort of the central, the pelvis and the spine maintain pretty good cellularity. So I would be perhaps a little cautious about using, trying to get marrow from an older subject, from that level. But again, we haven't done extensive studies on the counts. If there are cells in the marrow, this needle will get them out. It's really just a question of the marrow itself.
Yeah, I've used the marrow from the knee on younger patients, and I've had good success. But you're right. I mean, certainly when they're older, you have to go to the crest. No doubt about that.
Okay, and actually, the next question is back to you. Do you believe that removing some bone from the lesion and replacing it with transplanted bone has a benefit? Is this preferable compared to reaming a path through the lesion or simply injecting into the lesion from the edge?
Well, I mean, I think that's the same question. It's just the basis of, how do we stimulate the body's biology to heal? And it's usually, if you have a non-union, what does Taylor do? He corrects it down and gets rid of all the fibrous tissue, and you stimulate the body's ability to heal. So I think what we're doing, bone marrow edema, to me, in non-union or biologically, or subchondral fracture are biologically all equivalent, just in smaller scales. So I think finding the lesion accurately, removing the dysfunctional bone in terms of bone marrow edema, and then replanting it with aspirate and autograft is the key. What we would do on a non-union is what I do in subchondral bone. And I would say that using autograft is clearly superior than alternative tricalcium phosphates, which to me sometimes prevent bone healing as much as promote bone healing. Taylor, what do you think?
Yeah, I guess I don't know if part of that question was, do you take a dowel when you're looking at your, what you want to get rid of, are you taking a dowel out? Are you reaming through it? Or are you just kind of injecting around it? And I think it just depends on, that's an individualized answer, kind of like per patient. If you've got something that seems really sclerotic and you don't think is going to be easy to, you want to kind of clear a path and, break it up, then yeah, I think taking a dowel of that, even though it takes slightly longer, is worth it, or at least, reaming through it a couple times. So I think it just depends on, what substance you think you're trying to invade with your your marrow. And certainly if you're going to try to put in one of the dowels, I think clearing some space for that, especially with a harder lesion, is going to be worthwhile. Something like, just subchondral edema, or, insufficiency fracture or something, for instance, maybe you can then just, put the marrow directly into that lesion.
Okay, great. We have a couple more questions and probably have time for them. Dr. Reif, maybe this one for you. Are there any patients that you feel would not be a good candidate for percutaneous bone repair because of biological reasons like osteoporosis?
So I think osteoporosis is often maybe a little bit more systemic and is going to need to be addressed with medical therapies versus, there's only so much bone graft to go around. And, I think mostly what we're talking about here is more isolated lesions that you can really target. I'd say, and then other lesions that I would just be aware of is, if you're basing this on MRI or something, you want to make sure that you're not dealing with infection. This isn't meant to treat infection but on its own, or certainly something like a malignancy or a neoplasm. I think, you want to be careful that you're not just trying to inject, bone marrow there, because, just as long as you know what you're dealing with, and, it's something that could use the biological stimulus, that would, that's really what you're going for. And, then how big of a non-union is too big for this? I think that's again, that's a very individualized answer. And, but I think this is great for something that, it's like, you're kind of scratching your head wondering, like, oh man, that seems like it was so close to healing. What happened? And, if you can just stimulate that with a little bit more biology, you might get an arthrodesis or a non-union, which seem to have appropriate fixation to heal.
Yeah, I mean, my intrigue of when I was a young surgeon of bone marrow aspirate was really with proximal femoral fractures, and where we did, a nail on older people, and the nail was still stable in the proximal femur and the distal femur, but they limped tremendously, and there was an intertrochanteric non-union. And to take out that nail and then put a blade plate on and with iliac crest is a massive operation. And I did that once, and the patient expired. And after that, one of my teachers, Dr. Lane, who's really a Hernigu disciple, taught about doing some bone marrow aspirate. And it's not like an intertroch happens that often. It's a very vascularized area. They heal mostly, but we did a lot of them, and we would have 1 or 2 a year, and we were injected with bone marrow aspirate, and they all healed. So that really was my impetus to learn about more of this technology.
Okay, thank you very much. There are a couple more questions, but I think we'll probably have to respond to those through email because we're coming up on the top of the hour. If you are looking for any further information on the systems from Cervos, or if you have questions, you can always try to contact us through our webpage, cervos.com, and we'll be very happy to try to connect you with the answer to any other questions that you may have. Okay.
Thank you, Jeff. That was terrific. And this is one of the best courses I've seen in a while. And again, the cadaver lab was a real highlight, and the patient testimonial, really wonderful. So thank you, Dr. Ranawat, Dr. Reif, really well done. We have a short video that kind of summarizes some of the key points of this course for the audience. And again, most especially, thank you to the audience. You've been part of a great course this evening. Thank you. Go ahead with our final video.
Harnessing the power of bone marrow-derived stem cells through vasculogenesis to advance clinical outcomes. Bone marrow is such a precious resource that it is the most protected part of the body and resides deep inside bone cavities. Vasculogenesis is the process by which marrow stem cells move through the peripheral vasculature to the site of damage. Vasculogenesis is the engine of all tissue repair, making red marrow the engine of life. Sourcing cells from red marrow in an adult and transplanting it to the site of injury exactly mimics and supplements the body's response to injury, which degrades with age. Marrow stem cells orchestrate the transition from the inflammatory phase of the healing cascade to the proliferation and remodeling phase. Our best-in-class autologous and synthetic orthobiologic products mimic and promote vasculogenesis to treat a variety of musculoskeletal disorders and help grow bone, preserve joints, manage chronic pain, and restore your daily active lifestyle.
Thank you to all of our speakers today for an excellent program. And most importantly, thank you to all of our attendees for participating in this educational masterclass outlining the patient benefits of this amazing technology. On behalf of our sponsors, Cervos Medical, and today's master faculty, be safe and stay well.